I'm Rebecca Graff McRae. I'm one of the research managers at the Parkland Institute, and I'm going to be your host for today's webinar on Jennifer Jackson's new report for Parkland Ripple Effects, the Drug Toxicity Crisis, and its impact on frontline health workers. So hello and welcome. I'd like to open this afternoon by respectfully acknowledging that Parkland Institute is located on Treaty 6 territory, the traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Papischase, Nakota Sioux, Métis, Dene, Inuit, as well as the Haudenosaunee, the Ojibwe, Saulteaux, Anishinaabe nations, whose traditions and languages and footprints have marked this place since time immemorial and continue to shape it. Miskutiwaskahikin is a gathering place and a river route of exchange, and it is in this spirit that we meet here together to share knowledge and learn from each other's experiences with deep respect and reciprocity. And the work we're here to engage with today was also conducted from Treaty 7 land, Moginsis, the elbow, where rivers and hopefully ideas also converge. So I also want to reflect that the crisis fueled by the toxic drug supply has impacted people and families and communities across Alberta. And so wherever you are joining us from and wherever you call home, I welcome you to reflect on the ripple effects of colonialism and cultural genocide and systemic racism within our health and social care systems, past and present, and the ways in which too often what are meant to be systems of care can also perpetuate harmful legacies. So to consider some of those deep legacies and the ongoing and incomplete process of reconciliation as it relates to our health and social care and how we care for each other within our communities. And so with that, I would like to very excitedly introduce our speaker today, researcher Jennifer Jackson. She's a registered nurse and assistant professor in the Faculty of Nursing at the University of Calgary. Her research focuses on improving health services and supporting workers in community-based harm reduction, addiction, and mental health services. In addition to the report today, her publications include Differences in Overdose Rates by Gender at Supervised Consumption Sites, an explanatory sequential mixed method study, and Burnout and Resilience in Critical Care Nurses, a grounded theory of managing exposure. So with that, I'll turn it over to Jennifer for today's presentation. Thank you.
Great, thank you so much. I appreciate the warm welcome, Rebecca, and hello to colleagues and friends I see who have joined, as well as anybody who's interested in this topic, and hopefully I can shine a light on some of what's happening in Alberta as we talk for the next few minutes. So, all right, I think we've got the screen going. So today's report is Ripple Effects, and it's very aptly named because what we have known for a long time is that the opioid and drug poisoning crises here in Alberta has been very, very hard on patients. What I'm adding to this conversation today is that it is also very hard on healthcare professionals. Our current system is not working for anybody. So I'm hoping that we can provide some recommendations that Alberta Health and other parties can take forward, because we have lots of scope for improvement so that our healthcare services are better for people with addictions and healthcare professionals across the province. So what are we talking about when we say drug poisoning crisis? So we have record numbers of deaths of people who are dying from toxic drugs. Now, these are substances that are being used outside of a regulated market. So we know that when we purchase prescription drugs that come from accredited companies, that there is a high degree of quality control and testing, so that any substance that we get that says it's got vitamin D in it, 1,000 units, we know that that has 1,000 units of vitamin D in it. What's currently happening is that people with addictions are not able to access their substance of preference through the regulated market. So they're getting it from outside the market, which means that it's not regulated. So we can say that we hope that this pill has fentanyl in it, but we don't know how much. It might not have fentanyl at all. There might be other substances in there. And so that is why we use the term drug poisoning, is that people are being poisoned because they don't know what's in these substances they're consuming. The drugs that we have now, particularly things like fentanyl and crystal methamphetamine, these are much stronger than any other kinds of drugs we've had in the past. So sometimes I'm asked, why would people use toxic drugs? By the time that they are experiencing full addiction, perhaps homelessness as well, it is not a question of being able to stop. These drugs can rewire the chemistry in your body, and it does not leave people with a lot of choices. So the sort of cold turkey quitting is not something that's possible with this next generation of substances. I also just want to point out that opioids in themselves are not necessarily bad. So we talk a lot about fentanyl or opioids when we're talking about the drug poisoning crisis, but we can also use things like fentanyl for legitimate prescription and medical purposes. For example, opioids are a really necessary part of treating cancer pain. And I would never want someone to who's experiencing cancer or another major condition to be harmed because of a fear of these substances. So when they come through the regulated market and they have a prescribed purpose, it's not inherently bad. So I just want to make sure we don't throw the baby out with the bathwater, so to speak, that when we're outside the regulated market, that's where we're getting into trouble. So in the graph that you can see on your screen, I just want to point out that the last column there, that is only for 6 months. So kind of don't be tricked into thinking there's been a steep drop off so far. This is only 6 months of data. And even though we've seen a bit of a decrease the past year, that trend has been consistent across North America. That's not isolated only to Alberta. And also, even with that decrease, we are still having record numbers. You can see there that we're still much higher than before the pandemic. So we also know that we had more people die from drug poisonings in Alberta in 2020 than we did from COVID-19. So this has been with us for a while, but it is still very much a pressing public health concern, and it's having a big toll on our healthcare professionals here in Alberta. So what did we do? We wanted to look at what the province-wide impact is on healthcare professionals who are addressing the drug poisoning crisis. So we sent a survey to the Health Sciences Association of Alberta, and they are a union that represents healthcare professionals in Alberta who generally are not doctors and nurses. So they represent registered dietitians, social workers, psychologists, pharmacists, primary and advanced care paramedics, counselors, and many other professional roles. So they are represented across the spectrum of the healthcare system, from community-based services to intensive care units. So just about anybody you see that has a regulated role, that is not a doctor or nurse, that's who we were talking to. We asked them about their knowledge and attitudes towards opioids and people with addictions. We asked them about their quality of life and burnout at work, and if they were experiencing any workplace violence. After the surveys, we also conducted interviews with people across the province, and we spoke to them in more detail to learn about what does this actually look like for you, and what do these things mean in your daily life. And one of the main things we found is that the drug poisoning crisis is not over. Far from it. People with addictions are still using the healthcare system every single day. This is a constant presence, and represents a lot of the clients who are within our healthcare system in Alberta. So while we've seen changes in deaths from drug poisonings, this is not something that is going away. And it's having a marked impact on the work that people are doing across the province. So, what did we learn? We found that healthcare professionals want to help people with addictions. They have very supportive attitudes towards people with addictions, and they have a lot of empathy and understanding for people that are in difficult situations. However, they have not had as much training and education to support their practice in this area as they could. So we found that people have been educated about using naloxone kits. Naloxone is an antidote to an opioid poisoning. Those kits are available for free to anyone at almost every pharmacy in Alberta. So if you haven't had a chance to get one, you can pick one up next time you're in. So they've been educated on using the naloxone kits, but not much else. So there was a relatively low level of knowledge about drug poisonings and about the crisis, especially given that we're at almost a decade now, compared to the growth in knowledge people had with COVID-19 from where they started when we were all just trying to figure out where it is to where we are now. It's a very different story. We had a huge build in knowledge in COVID-19, I think among everybody in the general public, let alone healthcare professionals. But with drug poisonings, we haven't had that same increase. So healthcare professionals are lacking some of the continuing education that they would like to see to address this crisis. So we found that across the people who completed our survey, the burnout scores were medium. However, there's a second story happening here in that emergency professionals are in dire need of support. And when I say emergency professionals, I'm referring to emergency medical responders, primary care paramedics, and advanced care paramedics. But I will just say emergency professionals to have that is one grouping. Um, for anybody who's working at the street level, the impact of the drug poisoning crisis is much more severe than people who are working in hospitals. And the further you get away from the front door, so to speak, the less you are affected by it. So people in intensive care are generally less affected than people who are working in the emergency department. But emergency professionals have very high levels of burnout, and they are really, really struggling with this crisis. They face a lack of support, a lack of resources, and just feeling excluded generally across the healthcare system. So they feel like they're left to face this on their own without adequate resources. I'm not the first one who's kind of sounded the alarm here. I know the Parkland Institute has previously supported research on emergency responders in Alberta. And I guess the thing I can say now is things aren't getting better. We also found that there were very high rates of violence at work experienced by healthcare professionals. So you can see on your slide here that over half of the people that we surveyed had experienced emotional abuse at work more than 3 times in the past year. So virtually everybody is experiencing some kind of violence at work in the past year. We also see that people are more often feeling unsafe at work, experiencing threats, and given the context of the drug poisoning crisis, it's understandable why this is happening. So if we imagine you're in a community where there is no supervised consumption site, so you have to use drugs in an unsupportive environment, you can't stop, but there are no other options. So for example, you're in an alley behind a building, something like that. You experience a drug poisoning, you're unconscious, and then you wake up after healthcare professionals arrive. So we can see in an example, so if we think back to the movie Iron Man, um, when Tony Stark wakes up after the bombs have exploded, what is the first thing he does? He reaches for the tube in his nose and pulls it out. And he gets as far as grabbing the things on his chest before somebody says, I don't think you want to do that. And, the film continues from there. So I know that's an example from the Marvel Cinematic Universe, but like I have seen that clinically as a nurse all the time. The first thing you do when you wake up is try and get the stuff off of you. I think that's a very normal human reaction. Um, but what's happening in this context is somebody might be in an alleyway. They're trying to get the oxygen mask off or something as they're regaining consciousness. And that's putting the emergency professional who's there at risk because they're working with somebody who doesn't know where they are, doesn't know what's going on, and there is potential for workplace violence there because both of those people are being put in a bad situation. And that bad situation is occurring because we don't have other services that could act to prevent it. So this is a really difficult challenge because we know that we could be doing things differently in ways that could prevent some of this violence, but we're not seeing those policies being implemented. We also know that there's just high rates of frustration generally within the healthcare system. And if people have long wait times, they're not able to get transferred from the ambulance to the hospital. They're staying in the hospital emergency departments overnight. That's going to increase frustration. That doesn't make workplace violence okay, but we can understand why some of these situations are coming to exist. Also, very concerning is that people are not getting help. So they experience violence at work, but nearly 84% of them are not reaching out. Knowing how toxic violence at work can be, it's gravely concerning that people are not finding support for that after they've experienced violence. So, what do we recommend for these healthcare professionals? We found that when people could adapt their healthcare services locally, it decreased their burnout, and also they saw improvements in the system for them and for the clients they're working with. So, currently in our healthcare system, it's a very top down type of approach. So, most of the policies coming directly from Edmonton, from a head office type scenario, and it's being implemented uniformly across the province. What we need is to have those clear goals of what we want to achieve across the province, but allow for more local customization because we know that the needs that people have in Wetaskiwin or in Lethbridge are different than those in Fort McMurray or are different than those in the cities. So when we can support people to make changes locally, still within our healthcare system, but to customize what they're doing based on their clinical expertise, we find that that will improve the services that they can provide to their community. We need to enhance employee benefits, especially for coverage for things like mental health support. In general, our participants didn't trust internal programs and they wanted to go outside of their employer for um, their mental health support. And we had some people who were paramedics saying that they were spending a third of each paycheck on therapy just to be able to continue their job. And while I am very glad that they were able to spend that money and access those services, they should not have to have that high of an expense just to continue working day to day. So we need a big increase in the employee benefits as a stopgap to addressing the underlying reasons of why they are needing so much additional support. We need to support managers with more resources and training. And I know as soon as I say the word managers, people have a lot of different conceptions about what that means in healthcare. Here, I'm referring to the people who are sort of immediately supervising people working clinically. So these are folks that might have a staff of 150 to 300 people, and they're trying to make sure that everybody's got their requisite training, everybody's got the certifications they need, plus managing sick calls, quality improvement, all the other demands that are placed on those healthcare professionals. So it's much more cost effective if we can support those clinical managers because by perhaps sending one person to do some additional training, we can benefit that whole 150 person workforce. It's going to be a lot more cost effective and faster than if we go through each one of those 150 people. So we do need supports for the workforce generally, but we can also get really good kind of bang for our buck if we're supporting clinical managers and increasing their capacity. We can also do things like increase their admin support so they're able to spend more time with their staff and things like that. It's also time for increased options for job flexibility. We've seen during the pandemic, there have been a lot of changes to how flexible working takes place, and that's something that can be expanded to include roles in Alberta Health Services and in our healthcare system. For example, many people said, I really like working as a paramedic or an emergency professional, but I can't do this day in, day out. It's causing too much burnout, but I don't want to stop altogether. If I could do 50% here and then 50% maybe in education and quality improvement or in a non-clinical area, and I could still keep full-time pension and benefits, and I'm still working full-time, but maybe splitting that role between two different places. That would help us retain staff because the other option is they just leave entirely. So it's time to look at how we can keep people in full-time capacities, but maybe allow them to split hours between different environments so that they're not leaving altogether. Additionally, we need to allow for peer support and grief counseling. Now, this does not replace external support in a mental health capacity. We know that groups like, for example, here in Calgary, the Calgary Fire Department and the Calgary Police Service has 24-hour in-house psychology support available for free to everyone in their workforce. However, our emergency professionals who are at many of the same calls don't have anything of the kind. So we do need that professional support, but people also said they like to have time to talk with their colleagues, not violating anybody's privacy, but taking time to talk about like a client who has passed away, what they meant to them, and having a chance to debrief with other people who understand the situation and perhaps knew that person. So when their workloads are so high, they can't carve out any time for this. And participants told us it's very impactful in supporting their mental health and helping them continue in their roles. So we need to make sure they have opportunities for things like this at work that's still within a professional circle of care. We're not sharing any information inappropriately, but giving people a chance to debrief and talk about what's happened. Additionally, we also need to look at what we can do as big picture across our province to try and address the broader issues of the drug poisoning crisis. So we need to adopt a wide range of evidence-based addiction services. I've done studies here in Alberta, and I know many other colleagues have across the province. We've made heaps of recommendations, many of which are cost neutral, and I'd love to see those be implemented because we would get better care for people in Alberta. So often it's been vilified that if we have services like harm reduction and supervised consumption sites that we are enabling people to use drugs, we're not addressing the problems. In my experience, those kinds of services help people build relationships so they can come to other options and look at what kind of treatment might work for them. We also know right now we're having a centralization of our services around inpatient addiction and mental health treatment. And we do need more facilities where you would go, say, for a period of 90 days and stay there and go through an intensive process of counseling and support. We have wait lists for every single one of those in the province. We do need more of them, but we also need more services that are based in the community, things like supervised consumption sites or clinics where people can go, mental health services that are available for drop-ins. All of those kinds of things are substantially cheaper than inpatient services. So a visit to a supervised consumption site will cost you around $50 anywhere in Alberta. If you go to an emergency department, it's going to cost you $1,200 and up from there. So whenever we can provide health services in the community, they are substantially cheaper than anything else we should do. So we need to be including those as part of a comprehensive range of options for people with addictions in our province. We also need affordable housing. The gold standard currently is a housing first approach. The experience of not having stable housing is profoundly stressful. And if you don't have a safe place to sleep at night, you're not going to be able to start dealing with chronic mental health problems or complex trauma you experienced as a child. It's not fair of us to ask people to sort that all out while they don't have a safe place to live. So we need to create access to affordable housing. Again, my colleagues have done tons of research on this, and I really reject any ideas of we need to, put people in modified shipping containers or tiny houses or things like that. We need to offer people places with dignity that are safe and where they feel welcome. And that's a prerequisite to anybody healing with these kinds of challenges that they face. We need to increase access to and funding for prescriptions. And this applies broadly. I am in favor of universal pharmacare for everyone. This is especially important where we're talking about addictions because people may not have the resources to support medication that can make a huge difference to their recovery. So also, a lot of the prescribing of different medications that can support people with addictions, it's all been centralized into specialist clinics. So it's decreased access to people in rural areas. And so what we need to do is like maybe you need to have an appointment at a specialist clinic, but then can you go back to your family doctor or can your family doctor start that prescription? There's some medications that can only get through patches, or excuse me, they can only get through like tablets. Can we make them available through patches or injections or as much flexibility there as we can? We need to make sure people can access funding for prescriptions. There's some new medications that can be really helpful for people, but they're not yet available as generics. So how can we make sure we have drug coverage to support people so they're using substances that are inside the market and safer and not outside the market? If we can support people on medications that are from inside the market, they know they're not going to be poisoned when they're using that substance. So we can take away a massive amount of stress and fear. And from there, we can start to have conversations about what are the next steps? What is the long-term planning? But it's impossible to do that with anyone if they're in the middle of a crisis. Do not ask me to plan 10 days down the road if, I've just been in a car accident. So we can't place those expectations on someone else. That wouldn't be fair for us either. Additionally, we need to continue working on prevention. We know that if we have universal education, lots of support in the classroom for teachers and for other education professionals, and that we have parents who are not living in poverty, we can create a massive amount of benefit. If we can keep lots of support going for children from 0 to age 5, that's their most critical window. And I think that with a strong education system and universal childcare, that would put me out of business in 30 years and nothing would make me happier. So I think we have lots of options, and I hope that we'll see the adoptions of some of these or my colleagues' suggestions because we have lots of opportunities to make things better for people in Alberta. So just before I take questions, I'll thank everybody in the Wishes Nursing Lab who's made such a big difference in helping us to do this research and create this report. I'm very grateful for all their input, all the colleagues at the University of Calgary, and everybody else who's been a part of this work, Parkland Institute and others. So thank you very much.
Great. Thank you so very much for that overview of this really important research, Jennifer. And we've had a couple of questions come in through the Q&A. So just let everyone know that we'll try to condense or combine some of those if we can, to avoid repetition. But while we're waiting for a few more folks who might want to be ruminating on so much of that really helpful information, I'm going to take chair's prerogative, and pitch you one of my own. And as a policy researcher over here, I'm very aware that the provincial government has been very vocal about prioritizing a unique made in Alberta approach to resolving the toxic drugs crisis. But on the ground, and from what we've seen from your participants and from media reports and other people's experiences, that crisis has deepened, and workers are saying to you, and your researchers, that they're struggling to get supports. So how do we kind of square that circle between this perception that at the policy level there's a unique model that's being put in place and lots of attention being put on the issue, but it's not getting to the workers who are really trying to deliver that care on the ground?
Mhm. So there's always challenges with any policy of how does that trickle down or show up, when we have kind of broad ideas, how do they show up in our day-to-day services? I think what we're seeing here is that there's a strong ideological underpinning of drug policy in Alberta. And there seems to be a very set mental model from the creators of these policies of what should happen for people with addictions. So they need to get better, and they need to get better in a certain way and in a certain time frame. And getting better looks like this. Um, I can contrast that with other services. If we think of how we treat cancer in this province, we have lots of different options available to people. There's community-based clinics. They can see family doctors. They can see specialist clinics. There's groups for different types of cancer. You can get treatment in the city. There's treatment in rural areas. And I'm not saying that system is perfect, but when we have a scope of like everything that works is available to you, it creates a very different environment. We've seen a centralization of services around these inpatient treatment options, and while we do need that, we're desperately short of infrastructure in Alberta for supporting people with addiction and mental health issues. The idea that you get X number of days and then you're on your own, or that you have to leave your community to go somewhere else to get treatment, is very challenging. And what we've heard, both in this work and others, is that people who are working in community-based services are seeing increased demand. And what they're facing is closure or reduction of resources rather than an increase in resources. So if nobody was coming to the supervised consumption site, it would make sense to close it. But they are seeing hundreds, if not thousands, of people a day. So clearly there's demand for that service in our communities. So why aren't we responding to that with evidence-based policy? I think of myself as a radical pragmatist. I want to see things that work. When we're doing the same thing that hasn't been working or hasn't been working enough, I would love to see recognition that we have an opportunity to take things forward by adding in new options that let people choose their own adventure so that they can get better on their terms, which is what I would want for anybody with any chronic illness.
Yeah. Thank you so much, Jennifer. We've got a number of really thoughtful questions here coming in, and then I want to get to a few of the more maybe more complex ones here in a second that I'll combine. But one or two folks asking a little bit about kind of going back to the basic landscape here of, first of all, do we have provincially, you yourself or available to the public, a scope of the addiction crisis? What kind of data do we have on the number of Albertans who are experiencing drug and alcohol addiction? And also, do we know why, in particular, right now, it appears that overdoses are increasing in some areas more so than others. Even if for like you said for your graphs there that we haven't seen so far an upsurge in fatalities.
So there's a few different things there. I think one option is that the provincial government has consolidated a lot of these data around what's happening and in which zone into there's a surveillance dashboard online. Perhaps somebody can put the link to that in the chat, but there is a place where you can see information about hospitalizations. I believe it's emergency calls and deaths. And additionally, we have many researchers that are trying to do work around these things and look at these different topics. One of the challenges is that with the consolidation of services around Recovery Alberta, um, to make a long story short, they now vet all the research studies that are happening. And so it's challenging as a researcher to say, like, my obligation is to the facts and to reporting things as I find them. And if I can't access the healthcare service to ask people questions or to use these data, then it limits the ability of myself and others to tell those kinds of stories. So it's really important that when we're implementing these kinds of programs, like the Alberta Recovery Model, that we are able to have independent evaluation so we know if they're working, or more importantly, we know if they're causing harm. And can you remind me what the second part of that question
Yeah, the
was?
second part is around why certain areas may be experiencing an increase in overdoses. The question here came from Calgary Fire Department in particular, and so maybe around like what changes, what sort of factors in the local context, or perhaps in the wider context, are changing what that looks like on the ground in terms of the increase for people.
Yeah, so some of the things that we see is where the drugs are coming from. Um, So when we had things like cocaine and heroin, I'm sure we've all seen on TV, like where you have bricks of stuff that was being transported across borders and there's these very large shipments. Now, when we have substances like fentanyl, carfentanil, methamphetamines, you need such a small amount to provide a dose that, you can have something the size of a cell phone that can have thousands of doses in it. So it's changed how substances are moving around because it's in a different volume than what we've seen in the past. So we have quite a bit of our drug supply comes in from China and other countries through Vancouver. And then it also comes north from the US. We have some that's also made here, but it tends to be across the borders. And so that's part of why we see Vancouver has a very different kind of environment there because they're sort of the first port of call for two different entry points. And then the drugs sort of make their way across the mountains or further north and get to Calgary and Edmonton. So, it's sort of what's left by the time that reaches here, and that type of issue. So it's like what substances are around. We saw big changes when the borders were closed. The drugs were getting kind of more and more toxic to the point where some had Kool-Aid mixed into them and different things like that. So that we get a lot of provincial variation that way. I'll also just say that, sometimes Alberta gets compared to BC, and in this particular issue, it's really an apples and oranges kind of thing. In Vancouver, you can survive outside 365 days a year, generally. And in Calgary, you cannot. You will freeze to death if you're outside. So that factor alone, like the weather and the proximity to borders, means that in Vancouver, they're facing a different set of issues than we are here in Alberta. So one isn't better or like they're just different. And so if somebody's trying to say, well, we don't want to end up like Vancouver if we do ABC, it's not that simple.
Thank you for that, Jennifer. So the next question, I'm trying to weave together a little bit, a couple of different questions around the question, the concern around workplace violence for these healthcare workers. One in particular is wondering about that very striking quote that you had in your slides around, I think, EMS wearing bulletproof vests into the workplace. And so, if you could provide a little context around that, but also around maybe kind of breaking down a little bit about some of those experiences of violence that were shared with you, and whether that was perpetrated by managers, coworkers, or also clients, patients, and how that's experienced by the participants in your study.
Hmm. So I have to say that we didn't measure to the point of detecting like exactly the source of all of these incidents. So it could be coming from management, coworkers, patients' families, or patients themselves. So I don't want to make claims that it's only any one group. From my clinical expertise, I would say it's probably a combination and reflects a lot of frustration in the healthcare service and also trends that we see more broadly in our society. So, as a nurse, we see huge amounts of violence directed at nurses, but we also see huge amounts of violence directed at women. And nurses are primarily female, and so we end up with this spillover effect of we have violence in our society directed at women, and it ends up showing up in nurses. So we have racism, we have sexism in our province that will reflect upon people who are working in our emergency services. So individuals may be at increased risk because of their identity that way. That's not okay, but it's something that we need to be honest about so we can start to address that. Um, there's a few different things happening. Like when we have people who are using drugs outside of a supportive environment, like a supervised consumption site, um, there with the example I used with people might be in an alley. Another thing is that people might be using drugs in a home, and there might be needles on the ground after they've used drugs. And then if a paramedic is coming into that space, they have to work around those needles and they don't want to get poked by them. But if someone's unconscious, they couldn't necessarily clean them up. And, we think of like that person is using drugs in that home because they might not have other safe options. So I can see with these instances that people shared with me that there's a big system picture here, and people are being set up to fail. So it's the paradox of like we are all responsible for our actions, but also if we don't know where we are in a chemically altered state. There may not be any intent to cause harm. One of the challenges is also just with violence in healthcare generally, it can be really hard to have any repercussions. So if someone is attached to a dialysis machine or something else, for example, they're receiving chemotherapy, they could say something aggressive to the staff. Now, I can promise you that on the wall of that unit, there's some kind of sign that says zero tolerance and, we do not permit this kind of behavior. But what are we going to do? Throw somebody in their dialysis machine out the door? Like, of course not. So it ends up that a lot of that behavior has to be tolerated and can just continue. So I think we're putting people at risk, which doesn't need to be happening because if we had places like, I'm a big fan of supervised consumption sites. I think, we have bars all across the cities that manage the consumption of alcohol, make sure people are safe, and that happens day in and day out. That doesn't mean alcohol is benign and that it can't be harmful, but we've reached a model with alcohol where people can consume it in a way that they're not dying from being poisoned by it. So it's time to start looking at if we can have options like that, so we're not putting paramedics in these dangerous situations. Another thing to consider is that paramedics and emergency professionals may work by themselves, so that creates additional risk. I think there's an opportunity there to enhance communication among their teams and maybe look at dispatch. So there's some nuanced things there to consider. But I think it is important to recognize that we're putting people at risk and we need to take seriously their concerns. They had very clear visions of what they needed to be supported in their workplace, but they felt like nobody was listening.
Thank you very much, Jennifer. I'll just mention for the couple of folks who had asked for a little bit more of a dig down into some of those experiences. Our recent Parkland report, Undervalued and Overstretched, also broke down quite in a lot of detail around a similar subset of allied healthcare professionals and their experiences of workplace discrimination and abuse within employment from employers and coworkers. So that's also available on the Parkland website. A lot of the professions that you surveyed and in that other report overlap. So that's, I suppose, another factor is how much all of these situations within our healthcare system are compounding each other and adding to that stress load for these workers. So one thing I've been
Absolutely. That was some great work from Professor Jenny Godley here at the University of Calgary, and it shows none of this is happening in isolation. Our healthcare service is not an incubator set apart from our society. What's happening in our society shows up in our hospital.
Absolutely. I wanted to ask, I think which increasingly kind of entered the public discourse. We had recent municipal elections, and I know in Edmonton in particular, where I am, there was an awful lot of focus on community safety and a lot of rhetoric around safety that was only very lightly coded around, in particular, around addressing this crisis through increased law enforcement, increased criminalization, as opposed to looking at so many of the preventative measures that you've outlined, the social determinants of health as well, looking at housing and education. So I think a really important question that's been raised here is around the Compassionate Intervention Act and how you might feel the implementation of that act will sort of fall into this policy space. And do you think that healthcare workers who are having to implement some of the um, how do I put this, non-consensual intervention, how is that going to add to their feelings of agency around at this crisis?
Mhm. I I'm nodding because I can definitely relate to people who heard about this more in the elections. I've been talking about it more recently. I was recently at a social event and people were saying, "Oh, I can't go downtown anymore. It's way too dangerous." And I thought, I'm downtown like nearly every day and have been for years and haven't had a problem. Now, I know there are people who have experienced violence or been uncomfortable with an encounter, and I don't discount that. But if I could get one message to everybody, it's just because someone is poor and struggling does not mean they are dangerous. The vast majority of people that I encounter that are using drugs or pushing a shopping cart or whatever the case may be, they are just trying to survive the next few hours. They are just trying to think about how to get through the night without freezing to death outside. They frankly just don't they like all of us, they want to just be left alone to do whatever they're doing. So I think that people have conflated seeing someone who's poor with seeing a person who's dangerous. And that if we just don't see people who are visibly poor or visibly struggling, or, talking to someone we don't see, something like that, if we just don't see them, the problem's gone. What that's doing is people are being harassed away from the services. So in Calgary, we have a big centralization of services for people who are experiencing vulnerability, and they're in our downtown core. So if people are being pushed out of downtown, they're getting farther away from the things that can help them. And also, they're saying, okay, I don't want to have people giving me a hard time every minute. So I am going to use drugs instead in a more private or a more secluded place. I've seen people climb into like air vents and different things like that, behind garbage cans, like really unsafe places, just because they want to be left alone. And then that makes it that much harder for emergency professionals who might need to respond. Like they can't even physically get at someone, and they could die before they receive medical attention. So I think we all really need to think about our comfort level and like what do we want to achieve. I know for a long time, like we have a huge service gap here in Alberta. The majority of people who are currently using fentanyl prefer to smoke fentanyl or inhale it. And we have no supervised consumption site in the province that can support people who can inhale substances. All of it has to be injection to use those very limited facilities. So we have people that prefer to smoke, and there's nowhere that they can smoke. So what they had been doing was they would smoke near a transit station, finish smoking, then get on the train. And people were doing that so that if they were on the train and they experienced a drug poisoning, they hoped that somebody would call help so that they wouldn't die. And they were trying to be in a space where they were around other people so that people could find them and offer assistance. So to me, there's a specific logic there of someone trying to create a support mechanism when our social services have failed them. So if we push people off the trains or not on transit anymore, where are they going to go? So this is underscoring the crucial importance of affordable and dignified housing, and how if people have access to housing and we had more comprehensive supervised consumption sites, I think we would see a massive decrease in seeing people who are really struggling in our society. And so, if that's what makes us uncomfortable, we need to be addressing the root causes and helping people to choose other options, not just, vilifying them for existing in public. I'm very concerned to your next point about the Compassionate Intervention Act. I'm very concerned about this. I've read the full text of the legislation. As written, a police officer can enter your home and take your child without your consent, using force to put them into an addiction service facility in either Calgary or Edmonton. To me, that sounds like a residential school where someone could come and take your kids away and put them into a treatment facility. I think it's absolutely horrifying. And it also doesn't make any sense policy-wise. So even if we set aside the text of the legislation and what the legislation allows, we have wait lists of at least 3 months for almost every inpatient facility across the province. The detox facility here in Calgary, and I'm sure it's the same other places, they turn people away daily because they do not have enough beds. So why would we create legislation that forces people into treatment when we have an abundant number of people who desperately want this treatment and do consent to it? So it just seems really backwards to me, because we're creating more red tape. We are placing responsibility for mental health and public health problems onto a criminal system that is not designed to deal with them. And you know what? It's going to end up costing us a lot of money. Anytime we do something through a legal system instead of a health system, it's more expensive. So there's some issues that belong in each of these, and we need to kind of make sure we're not crossing the wires there. I think it will only increase burnout if we're forcing healthcare professionals to do things that they don't want to do. And if we've got places where people can't consent to their treatment, like how effective is that going to be? There's just so many holes in that policy proposal. I think it really needs to be reconsidered because there's potential for a lot of harm.
Right. Thank you so much for that, Jennifer. And I think that really underscores the opportunity here to learn from the experiences from the healthcare workers that you have interviewed, and the wider group who are working very hard to try to deliver care in challenging circumstances. And rather than ignoring those experiences and the learnings we can take from them, to continue sort of down a road that doesn't appear to be very effective. It would be, I think, to everyone's benefit to be able to find the balance in those approaches, and to think about that sort of, it sounds very cliche, but first do no harm. And I think that so many healthcare professionals and social care professionals take that really to heart. So I hugely appreciate your willingness to answer questions, and I hope that this is the beginning of a more critical conversation in our province around how our policy approach to this crisis is inadequate, and who's paying the cost for that. So thank you so very much. I know there were so many questions that we weren't able to get to, but thank you so much for the information. And I would like to remind everybody who's attending, first of all, thank you so much for being here. You can access the full report as well as a summary at parklandinstitute.ca. The link's in the chat for you. And the most important thing, I suppose, is just to know that we can't produce research like this without the support of everyone here in this room. Parkland Institute, it only functions through donation, and that's how we're able to keep putting out important data that is essential for trying to change the policy direction here and improves better outcomes for Albertans. So thank you again so much. Again, for anyone who's interested in setting up a media availability, can contact Heather. Heather's details should be in the chat as well. And I'd like to wish everyone a good afternoon, and thank you again.
Yeah, thank you so much. And if I didn't get a chance to answer your question, if you just look me up, my email is on the internet and I'd be happy to respond to you. So feel free to reach out.
Brilliant. Thank you, everyone. And thank you again. A huge round of applause to Jennifer. Thanks.